Or who's going to tell us about the new National Center for Advancing Translational Science. Francois?
Very, very pleased to be here. Thank you very much, Dr. Sullivan, Dr. Collis, Dr. Schwartz, and others. I must say that I'm not going to say much that you don't know, because really, first of all, I have recently joined this hospital, which you, this CTSA enterprise, in which you have been involved for so many years. So there are many things about it you know better than I do. But anyway, I'll tell you my point of view. First of all, unfortunately, I have nothing to disclose. Sometimes, now, thank you very much for your nice introduction. You know my life better than I do. Sometimes I have to say, you know, despite my accent and my name, I am not French. I was born in Switzerland, next to Montreux. And when I was a child, my family moved to Italy, so that's where I grew up and was educated. Went to medical school, and when I finished my training, I had actually I got a scholarship, and I had opportunity of going to 2 places. And you know, this was years ago, I didn't know that much about the world and myself at the United States, and I almost tossed the coin. The 2 places were Iowa and Massachusetts. And somehow it came out as Massachusetts.
Marsha, do you know Lily?
I'm so familiar. I'm from UMass Boston.
She is from Fall River. She's on our grade with us. She's one of our community partners.
Right, I thought the name, definitely, but also you look so familiar.
Is from UMass Dartmouth and Lori Keogh. And Lori is assistant professor in the community nursing department in the College of Nursing, and is also a postdoc in cancer and health disparities at UMass Boston. And Lori, I'll let you introduce your collaborator.
Hello everyone, I'd like to thank you for having us here today. We're very excited to be here. I have the pleasure of introducing our collaborators, Dr. David Weed, who is over here with the video camera. He's the coordinator of the Healthy City Fall River Initiative, Partners for a Healthier Community in Fall River, Massachusetts. He's responsible for the planning, development, and evaluation of citywide health programs that bring together the efforts of over 200 participating organizations to improve the health at the community level. Joining us is also Marsha Picard, his colleague, and she is the Fall River School Wellness Coordinator under the Partners for a Healthier Community. She works with the school department administration, the school committee, nutrition staff, and the citywide health and physical education staff. Ms. Picard is helping the Fall River District move forward toward a healthier environment for all students. And last but not least is my colleague, Professor Maria Vasquez. She's a full-time lecturer of community nursing at the College of Nursing at UMass Dartmouth in the same department as I. She is entering the districtification phase for a PhD program, and her research interest explores the integration of somatic embryology learning and nursing education. We've elected to have all of us present today except for Dr. Weed, who's, as you can see, videoing. So we're going to start off with Maria first. We're going to move to Marsha, and then I finish up the presentation.
Thank you, Lori. Good afternoon, everyone. Well, our study was called REACH. It stands for Readiness and Engagement Approach to Children's Health. And children's health was the primary focus of this pilot study. We're delighted to share our preliminary findings with all of you this afternoon. And, there we go, sorry. We have no actual or potential conflicts of interest to disclose at this time. And we would like to extend a special acknowledgement to our grant funders, the National Center for Research Resources, National Center for Advancing Translational Sciences, and the NIH, all of whom contributed to the grant offered by the Center for Clinical and Translational Science Research. As mentioned, Dr. Keogh is currently involved in a postdoctoral fellowship studying cancer and health disparities. Her involvement with the fellowship has provided additional guidance for the execution of this project. This study originated from this team's concern over increasing childhood obesity rates in Fall River, Massachusetts. We surmise that the best first step in engage the caretakers of school-aged children and explore how they perceive their children's health and what they believe to be the role of schools and other community resources in helping them to maximize their family's health. The data collected would provide the foundation on which to base a formative survey for future intervention research. Our study design was strictly exploratory and used a focus group approach to data collection, guided by principles of community-based participatory research. According to the Community Health Scholars Program, a W.K. Kellogg Foundation-funded postdoctoral fellowship program, CBPR is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. It begins with a research topic of importance to the community and has the aim of combining knowledge with action to achieve social change. We like to think of it as the grassroots approach to research. Although we did not follow a strict CBPR format, it prompted us to share research responsibilities with our community partners every step along the way. In an effort to offer all caregivers of the school-age children a voice in the study, we kept the sampling criteria as simple as possible. Participants simply had to be over 18 years of age and be a caregiver to a child or children enrolled in the Fall River Public School System. And at this time, I'll have Marsha come up and talk a little bit about the community engagement.
We have a number of different audiences for our focus groups, all of which tend to be comprised of family adults with children in the Fall River Public Schools, ideally ethnically and racially diverse as well. Dr. Weed, Dave, and I had worked with Maria before on a BMI data collection project within the Fall River School System, so we three had already established a strong symbiotic relationship. This new project, the REACH project, which now involved Laurie as well, was a perfect blend of what Laurie and Maria needed, along with what Dave and I could provide, that being an awareness of the Fall River community, as well as potential connections within the city. The success of our project was largely dependent on our being able to connect with the right people from the right agencies in as short amount of time as possible. We also needed to ensure that a strong sense of trust existed in potential agency representatives in order for that research to be of optimum value and for it to move along expeditiously. Because Laurie and Maria were not as familiar with the Fall River community as Dave and I were, and still are, he and I stepped in to help expedite that component of the project. In addition, when it came to the development of recruitment materials for the project, the public at large, as well as the demographic forms to be completed by the actual focus group participants and the discussion questions to be asked of them, Dave and I had a strong sense of what might and might not be palatable for our intended Fall River audiences, while Laurie and Maria knew what needed to be accomplished from a research perspective. Accordingly, we each were able to bring to that table our own area of expertise, which resulted in final documents that met the project's needs while ensuring that all wording stayed well within the parameters of the funder's requirements. Process. As longtime health and human service professionals based in Fall River, Dave and I were not only able to identify the most viable leads for this research, but arranged for and participated in numerous appointments with Fall River agency directors, saving considerable time that might have been lost had Laurie and Maria come into this project on their own and been left to determine those appropriate leads through a time-consuming, frustrating, though often necessary system of cold calling. And we all know what that's like when you spend 20 minutes on the phone trying to explain to somebody that something needs to be fixed at home, whether it's your TV or whatever. You spend 20 minutes talking to Mary. At the end of the conversation, you really need to talk to Joe. You spent 20 minutes talking to Joe. You really need to talk to Susan. So we helped you to cut through all of that red tape and get to the people with whom they needed to meet. As a result of our combined complementary expertise, we were able to connect with representatives from the school district, various youth-serving agencies, as well as members of formalized neighborhood groups. These connections ranged from speculative presentations at group gatherings to individual appointments designed to move quickly from a promotional stage to actual focus group facilitation. As was our goal, all these connections involved people who worked extensively with family adults from very diverse populations or were specifically representative of those diverse populations themselves. As more and more connections were made, more and more recruitment methods were tried, leading to a variety of group configurations, which Maria will now describe.
We originally planned to have 4 focus groups. 4 focus groups with 8 to 10 participants each. However, due to some less than optimal turnouts, we adjusted our recruiting plan by offering more groups with fewer participants in each, for a grand total of 9 groups at 6 different locations in the Fall River area. This was found to be more manageable and appropriate given that many of the groups were held in mixed languages. As you can see, the groups were quite diverse and truly representative of the predominant cultures and languages spoken in the area. Our sample size was a total of 28. Mean age was about 35 years of age. The actual sample was predominantly female, and despite assurance from the researchers that all would be kept confidential and anonymous, some of the participants declined completing the section of the demographic form inquiring about their ethnicity and race. So statistics related to these items are based on 22 and 17 respondents, respectively. This speaks to the level of trust needed when working with diverse groups and might be concerned about immigration status or other social service issues in the area. The education of our sample, a total of 27, had 19 participants that had completed a high school education, and about 26% had less than a high school education. Only 1 participant had actually completed a college degree. And as far as the marital status, more than half of the sample were single moms, at about 62%, and the remaining were married. As far as household income, this was a very impoverished group. 93% of the participants of the sample had a household income below $35,000 a year, and 56% of the total sample had less than $15,000 in terms of their annual household income. This was rather surprising considering that close to 40% of the sample did have 2 adults living in the home, and 70% did have at least a high school education. So at this time, I will have Lori come up and talk to you a little bit about the aims and the results that we received.
The first was to determine the caregiver's awareness and concerns related to their children's weight and the health effects that might be associated with an increased weight. In terms of awareness, 91% of our respondents did not perceive their child as overweight or obese. Yet when we calculated BMI for the children of our study sample, almost 50% of the children were indeed overweight and obese categories. We did find that parents were concerned about obesity, and most of the parents understood diabetes as a sequelae of obesity, but not other illnesses, for instance, cardiovascular disease, cancer, or respiratory problems. So this suggested to us that our participants may not have fully understood all of the health issues that may be associated with being overweight or obese. Some parents expressed some concerns surrounding weight but acknowledged competing interests, such as school or their own work, from engaging in behaviors that would lend themselves to a healthy lifestyle and aimed at decreasing weight and increasing exercise. Some felt it was not problematic at all. One participant told us, and I quote, "Well, if it's not affecting them in any way, they can still be overweight, but they're getting all the sports done and they're still going fine. They work fine, so it's not really affecting them." These results are consistent with the growing body of literature that supports that parental perceptions of children's weight may not be accurate in terms of actual weight. Our second aim was to better understand what the perceived role of the community and schools were in helping families optimize their health. We wanted to understand if health was viewed as a family matter or a collaborative process between the schools and communities. Although most did feel that the schools had an important role and the communities had an important role, this was limited depending on what element of health we were discussing. A few participants felt that schools should teach about good nutrition. However, the vast majority cited the roles of school agencies and schools and community agencies were to provide their children with healthy foods while they're enrolled in their care. Indeed, interestingly, in spite of the fact that 75% of the Fall River community is eligible and does participate in free and reduced lunch, 100% of our sample had free or reduced lunch. When we asked about concerns with schools, and if schools had a right to have concerns about children's weight, One mother felt it was not their business, and some agreed with her. It was a very sensitive topic in all the groups we did, as evidenced by this quote. Well, I would say I would like to think of myself as intelligent enough to know when my child's overweight, and I do expect them to have healthy options at school, and I approve of them keeping candy, cookies, and soda out of the classroom and out of the lunchroom. But let me be a parent. Let me help my child learn good eating habits at home. So we also wanted to know what the predictors for community resource utilization would be. So to better understand, we asked the families what made them use a community resource. And what we learned from this was that social networking was a key variable. If they determined that from a friend or a colleague that a service was good, they would utilize it. Conversely, if there was a negative reputation regarding the service or a community agency, it would generally not be utilized. By and large, all of our participants told us that if they really needed the service, they would use it regardless of how they were treated when they went there. For example, one African American participant became very upset. She described a situation that she perceived as being discriminatory at a local agency, but she needed the resource very badly, and therefore she went anyway. So we also wanted to know what some of the barriers were. We all know that common barriers to living a healthy lifestyle, such as time and issues of the like, and we wanted to understand it from our community's perspective, so we asked them. Some of the barriers were anticipated, as I said, financial, time. Others were not, however. For instance, transportation was a major issue. We were unaware of this. We had not considered this. There was no bus service after 6 p.m. and limited scheduling on the weekends. In addition, many community agencies had limited schedules in the evening and the weekends, therefore impeding use to the community at large during these times. Perhaps one of the most prominent barriers that we encountered over and over again were documentation and forms. It was clear to us that many participants did not want to fill out the forms that may be required to fill out to use community agencies. And there was an agreement on the part of participants on the reluctance to give demographic information, and we saw that in our study as well. As one participant said to us, she said, no questions, not asking about how much income they get, and not asking questions. You want to come? You're welcome to come. Facilitators were also counteractive barriers. For instance, we talked about social networking. Social network was a key variable in having people use community agencies that they perceived to be useful and user-friendly to their families. Cost and quality were also of importance, as was transportation and those facilities in walking distance. Parents cited that programs that were implemented in schools were helpful because most of the times the schools were in the same neighborhoods that they lived in. So in summary, to some extent, most participants understood that unhealthy leaves were problematic, although not always to the most comprehensive extent. Schools and community agencies were major stakeholders, and although families seemed open to their involvement, weight was a very sensitive topic. Some participants cited the need for more adult education, specifically surrounding how to eat healthier for them and their families. They also really felt as if the schools had an obligation to feed their children well while in their care. No mention of exercise by the participants at all. So future directions, where are we going? So right now we're in the process of dissemination where we've disseminated to the community at large. We're still in the process of doing that. We will invite back our research participants as well as the community agencies that we worked in, and we're in the process of doing that now. We need to further explore the community's readiness for behavior change aimed at healthy lifestyles. And we'd also like to understand the youth's perspectives on healthy living and healthy lifestyles as well. Any future interventions will need to engage the community, be sustainable, and very well thought out. And if there are any questions, I think we're going to do this at the end.
Can I ask, how many of these parents were illegal, or do you know?
We don't know.
You don't.
I asked the question of how many parents that enrolled in our studies were here illegally or undocumented, and we do not know.
So it makes people reticent to give information.
Yes,
In my experience, that providers of health care for lower income youth tend to think in terms of pregnancy, drugs, violence, mental illness, sexually transmitted diseases, abuse, bullying. I'm not sure how much of a priority they give kids who are just overweight. and they think in terms of limited resources and other objectives that they think are more important. I don't know whether, is that playing over the parents also? Because the parents think that, you know, as long as my kid's not really in trouble, it's not such a big deal for them.
You're exactly correct. Parents did not perceive this as a priority, and they did cite other competing interests as priorities. Bullying was one, academic achievement were others. They didn't see the problem with it. Because as you say, sometimes the sequelae aren't tangible, so they don't see the issues. You're correct. Right.
Which is probably a correct priority. I mean, just to get our priorities straight, you know. Which is not to say that this isn't important,
Yeah, okay.
but they may have a correct assessment.
Some of the outcome measures that you see with exercise, we tend to measure the biological outcome measures, but we don't always look at things such as, you know, well, sometimes we do, things like self-esteem and universal self-care. You know, I like to think that sometimes when you're invested in yourself and you think enough of yourself to exercise and eat healthy, perhaps other things will fall into place. For instance, my academics. Or maybe I don't want to do drugs because I'm going to go running tomorrow or something of that nature. So I like to think of it as something to help put them on the right track. I'm actually working on a separate but unrelated study with prison youth around the same topic area. People look at me like I'm crazy because they think there's so many other issues that affect that population. Why would I look at this? And I feel because it will all.
Children, people. Thank you. Thank you, Laura.